This is done for some patients that have a senile hollowing. This has just happened to them with age. They have a thin and recessed eye. And in other patients, they've had eyelid surgery or trauma and have recession and a deep sulcus. Injection into this area, just inferior to the superior orbital rim, can make the sulcus look fuller, which it looks like when we're at youth. What we've done here is raised a very thin skin flap, and we're going to lift the skin up off the eyelid. And as we lift it up, what we stare at is the orbicularis oculi muscle, which is a concentric muscle, a sphincteric type of muscle around the eye. It is the protractor for the eye. Some of it is over the tarsus. We see the tarsus here. The tarsus is the connective tissue support for the upper eyelid. The area in front of the tarsus is called the pretarsal orbicularis oculi. Just above this is the preseptal orbicularis oculi, and then more superior is the orbital orbicularis oculi. That goes way up into the forehead. An injection into the sulcus is performed deep to the orbicularis. So if this is the eyelid crease or the supratarsal crease, we would like the injection to be just below the orbital rim. And we feel the orbital rim there. Often we put our finger on it, we feel it. We perforate into that with either a needle or a cannula, and we put injection into this area to fill it out ever so gently. What we can do is make a small incision in the orbicularis oculi muscle and show where that would be. So if we take a strip of muscle from the orbicularis oculi muscle, obviously, surgically, we never want to take too much orbicularis out. And then we can retract this superiorly. This exposes the eye fat. Now what we're looking at is what's known as the pre-aponeurotic fat. This is the deep fat of the eyelid. Just deep to that is the levator aponeurosis. This layer pulls up and retracts the eyelid. Where we would like our filler to be is just deep to the orbicularis in this area and just on top of the eye fat and certainly superficial to the levator aponeurosis of the eyelid. So this is filler that goes underneath the orbit in a superior to inferior, just inferior to the orbital rim, just deep to the orbicularis oculi muscle, and that fills out the sulcus. You can see I'm putting a lot of it in, more than I would normally, and that makes the eye look a little puffy in this area. Now I would never inject quite this much and this fast, but you can see how it puffs out the eye there. And that's what we want to do. Now, normally I would do this with either a cannula or a very small 30 gauge needle, putting very small aliquots into this area. Notice we want to fill the sulcus from above down. We don't put the filler right at the supratarsal crease. We fill it from above the bone down. The sulcus injection in the left upper eyelid has been performed. If you look at that, it fills out the sulcus laterally. Now, depending upon what the individual patient needs, you can fill it out more centrally or more medially. Because I'm sitting here laterally, I've only done the sulcus injection laterally. Now we've also cut into the septum, and we're going to elevate this to show the anatomy. We're actually lifting up the area where we put the hyaluronic acid gel. But note, where we'd like the gel is outside of the fat, but inside from a superior-inferior dimension, the confines of the orbit. We don't want it in the orbit, because in the orbit would be violating the septum. Now we have violated the septum here, and we're looking at the deep fat, which are the couple of fat components of the eyelid. This is the bony rim, this is the corrugator, as we see it attaching to the medial bony rim, And here's where we put the sulcus injection. Now, if we were to put an injection here, this would be the roof retroorbicularis oculi fat injection filling out the eyebrow. So the sulcus injection is here, which is below the rim of the orbit. The brow or roof injection is here, above the bony rim. Both of them are outside of the orbit, orbital confines, because up here we're actually outside of the orbit, obviously, because there's bone. But down here we're outside of the orbit because we not like to violate the septum orbitale. We'd like it outside the fat. The reason we want to do that is we don't want to bleed, which would go inside the orbit. This is a right hemicadaver, and we're going to lift a SMAS platysma flap off. A skin flap has already been raised. We're going to lift the SMAS platysma flap and expose the underlying anatomy. Here is the masseter muscle as it comes from the inferior mandible and attaches to the angle of the mandible and the inferior mandible. Seen in the fascia overlying the masseter muscle are the buccal branches of the facial nerve. If we pull up on the inferior fibers of the masseter muscle, we see the marginal mandibular nerve. It's actually just below the mandible, and it requires us pulling up to see that single fiber. The nerve divides into a superior and an inferior branch. The nerve just overlays the facial artery, which we see coming into view here and becoming tortuous and going toward the corner of the mouth and the oral commissure. If we pull up on this anatomy, we see the facial artery down below. The artery comes from this area, it comes in this direction, and it comes up over the mandible. The vein is behind it. We're staring at the submandibular gland. We're looking at the sternocleidomastoid muscle. In order to show that, I've had to violate the deep cervical fascia that overlies the sternocleidomastoid muscle. The reason for this dissection and for showing this is what is present more posteriorly. This is the great auricular nerve, cervical branches C2 and 3. This nerve comes up and branches into both an anterior and posterior division. The posterior division goes more toward the ear, supplying the anterior surface of the lower half of the ear and supplying some skin near the angle of the mandible. More anterior divisions are directed this way. Just in front of this is the external jugular vein, which also runs in the fascia overlying the sternocleidomastoid muscle. An interesting thing about the great auricular nerve C2 and 3 is it's the most frequently injured nerve during a facelift operation, causing decreased sensation, anesthesia around the ear, around the posterior upper neck skin, and it can cause some itching in this area as it grows back if it is cut. This nerve also, interestingly, is the only nerve that's not a portion of the trigeminal nerve to supply any of the face. Even though it supplies some of the anterior neck skin, it's the only nerve to supply the skin overlying the angle of the mandible. That's C2 and 3. All the rest come from V1, V2, V3, branches of the trigeminal nerve, which have sensory branches. But the great auricular nerve supplies a little bit of the face over the angle of the mandible, and it is the only non-trigeminal nerve to supply sensation to the face. It's important to be immediately subcutaneous so as to not violate this fascia and to not injure this nerve.
So I would like to show you the situation in the mandibular region. Here is the mandible, of this patient, and we can clearly see that the facial artery is more anterior than the facial vein. The facial vein is straight towards the medial canthus, while the facial artery is rather towards the commissure of the mouth. But the facial artery is always curvy, the facial vein is always straight. You can see little branches of the facial artery here, many branches. And then usually here the marginal mandibular nerve crosses these vessels, and this nerve is always more superficial than they. So what we see here is the vaccinator muscle. They lay on the vaccinator muscle, and here is a big muscle. This is the anterior edge of the masseter muscle. I would like to show you the superior labial artery, how deep it is. We know that the superior labial artery must be deep in the lip. Now I did already the dissection, so I would like to show you that we have a skin subcutaneous fat, and then in the muscle, deep in the muscle, we can see the superior labial artery. And now in a moment I would like to show you how far we are from the rim. Here laterally we are approximately 8 millimeter far. So obviously it's not totally precise, but quite a good 4 millimeter, 3 millimeter. So let's see the inferior labial artery. In this case, it's obvious that the inferior labial artery is really far away from the inferior lip. So we cannot inject that. I would like to show you the relationship between the nasolabial fold and the facial artery. I cut here through the skin, and then let's see how deep is the facial artery. If we start our dissection, then it becomes obvious that we have a skin, subcutaneous fat, and then the facial arteries. So here we can inject superficially, it's no problem. Then it's still deep, as you can see this clearly. Deep, deep, deep. And then here it's underneath the levator labii superioris alaquae nasi muscle. You can see here muscle fibers, so it's underneath it, but more superficial than here. Here it gives a branch. This will be the subnasal artery, and then it pierces the levator labii superioris alaquae nasi muscle, and will become more and more superficial, and it will be finally the lateral nasal artery. So this is the course of the facial artery. It terminates in this case now into the lateral nasal artery. If we would like to inject hyaluronic acid here in the alar region, we have to be very superficial or deeper, but not in the middle, because here in this region the artery will be very superficial. Not very superficial, but more superficial than it was. I would like to measure for you how deep is this artery. It's 3 millimeters deep, 2 millimeters, 3. But here it's almost 4 or 5.